For the next presentation, Mbereko+Men Partners for MTCT, Impact of Gender-Synchronized Community-Based Intervention on Maternal, Mental Health, and Care Seeking in Rural Zimbabwe. Dr. Karen Webb, please.
Hi, good morning, everyone. It's wonderful to be here this morning, and we've had such great presentations about modeling and clinical science. And so I'm going to take us into the community and talk about the Mbereko+Men intervention that we implemented in Zimbabwe. So as a bit of background, Zimbabwe has an HIV prevalence of 14.8% among women of childbearing age. And this equates, as Dr. Mashavi said earlier, to 58,000 plus women who will require PMTCT services in an annual year. We know about the PMTCT cascade. We all know. We have evidence-based interventions to achieve PMTCT and optimize maternal and child health. We also know that male involvement improves maternal health seeking and outcomes. 1 in 5 women in lower middle income countries are affected by common perinatal mental disorders. And this comorbidity may influence health seeking and also contribute to adverse outcomes and growth and development of infants. Integrated PMTCT and MNCH, we've been talking about it yesterday and today. We know that it's required to reach elimination, but the question is how? So Mbereko+Men is a multi-component, gender-synchronized, community-based intervention that's intended to start to explore that question and understand. So as you can see, this hive of activity in the middle, that was our original model for Mbereko. And it's important to note that this is a model that's been iteratively refined over the past decade in Zimbabwe, together through participatory community-based research, as well as working with Ministry of Health and Child Care. So in the first case, Mbereko, it's women's empowerment groups. And these involve facilitated problem-solving sessions in which women, together with trained village health care workers, work together to explore and problem-solve barriers to uptake of PMTCT services. We also include income generation activities through internal savings and lending clubs and psychosocial support. The +Men component involves men's facilitated dialogue sessions and the facilitation of family charters, which is at the end of each session, men, through a consensus-based process, establish what they will do and commit to support women and children. For example, gender-based violence. One of the resolutions was zero tolerance for violence in our community. And then there's also active engagement with facility and community stakeholders. So our goal was to measure the impact of Mbereko+Men on maternal mental health, health seeking, and male engagement in care and support. Our primary outcome of interest was women's mean score on the locally validated Shona language version of the Edinburgh Postnatal Depression Scale, with a cutoff score of equal to or greater than 12 for clinically significant symptoms of anxiety and depression. Secondary outcomes explored included care seeking, men's supportive behaviors, and gender dynamics and co-parent relationships. And just to put it into context, this is the context in which many women in our study seek to access care. It's a very long walk to the health facility, and there's many barriers to get there. So we designed a cluster randomized controlled pragmatic trial. Pragmatic in the sense that the research aspects were only at the beginning and at the end. The programmatic aspects were allowed to continue as they would in a natural programmatic setting. Participants were women who had given birth within the previous 6 months and their male co-parents. Our sampling unit was 8 rural health facilities, 4 intervention and 4 control, randomly selected in Mutasa district, the district in yellow at the beginning of the slide of our introduction, which has one of the highest rates of maternal and infant mortality in Zimbabwe. Data were collected through 2 independent cross-sectional surveys before and after the intervention implementation. We conducted regression analyses, which were adjusted for age, education, and number of pregnancies, and also cluster effects with a significance of 0.05. So we through the two separate enumerations, we enumerated a total of 890 women and 515 male co-parents through both surveys. 11.7% of the women self-identified as HIV positive, so had a known HIV positive and were willing to disclose that during enumeration. Participant characteristics were similar between the two study arms. So looking at our first outcome of interest, maternal mental health, we saw reductions in Edinburgh postnatal depression scores in both intervention and control arms from baseline into final assessment. And we don't really know the reasons for this. This requires further investigation. It could have to do with economic reasons, dollarization in Zimbabwe, or political, because we were going through a political transition at that time. But what was important is that the decline in mean EPDS score was 34% greater in the intervention arm compared to the control arm. And when we looked at the individual characteristics associated with anxiety and depression in women enumerated, we saw that HIV positive status and, importantly, intimate partner violence in the previous 12 months was highly significant for anxiety and depression. When looking at the health-seeking behaviors across the PMTCT cascade, we saw that care-seeking was significantly higher in the intervention arm across multiple, what we call persistently problematic PMTCT cascade indicators. I think some of our colleagues mentioned it earlier. Early ANC uptake, couples HIV testing during pregnancy, and timely access to postnatal care for both mother and baby. So what we've heard yesterday and today, we also know that timing is everything for preventing mother-to-child transmission and infant deaths. So looking at couples' relationships and dynamics, I'm not going to get into too much detail on this because it's not the specific objective of the talk today, but what's important is that there was a significant impact of the Mbereko+Men intervention on submeasures of overall relationship dynamics, improved men's gender attitudes, and increased men's practical support in the home. Men in the Mbereko intervention sites were more involved in cooking in the home for their wives during pregnancy and lactation. They accompanied their wives and their babies to the health facility more, and they also played with their infants at the household level more. So limitations, I'm sure you're all thinking of a number, and this is a substantial challenge of integration in PMTCT to really identify and isolate our mechanisms of action and understand the implementation fidelity aspects. So we didn't measure our funding, and our timelines did not measure clinical outcomes for either MNCH or PMTCT. We didn't measure the relative contribution of different mechanisms of action. For example, the differential impacts of Mbereko on their own versus +Men on its own versus the combined intervention. And then, importantly, we didn't measure the impact of the intervention on men. How does Mbereko+Men improve men's mental health and their own care seeking? And we know this is a really important group for reaching epidemic control. For long-term impacts of Mbereko+Men, we need to look at the child health and development outcomes. So in conclusion, 3 key takeaways. We had a lot of learning in the process and in the implementation fidelity investigations through the program, but I think really what's important is that women living with HIV and survivors of intimate partner violence require targeted mental health support. Also, we demonstrate that a low-intensity gender-synchronized intervention can positively impact upon maternal mental health, PMTCT cascade strengthening, and also improve couples' relationships in the context of gender inequality. We're really seeking to do additional mixed method implementation research together with our academic partners, and this is required to understand some of these complexities and interactions for integrated programs and how they can be implemented cost-effectively at scale. So I'd like to thank our funders at the Burnett Institute and DFAT through the ANCP program, and of course, Ministry of Health and Child Care, and most importantly, the Mbereko mothers and fathers. Thank you very much.
Thank you.